All right, so uh, welcome to the first dialysis, or it's actually just going to be sharp end of the needle talk. So SEN talk. Um, I'm Bill Peckham. I publish sharp end of the needle, and I'm here with Ann O'Hare. Ann, you can introduce yourself.
Great. Well, thanks for having me, Bill. I am a nephrologist at the VA in Seattle and professor of medicine at the University of Washington. And I'm delighted to be here.
Yeah, and we're both, I should say, I'm a volunteer with the Kidney Research Institute, and I'm picking up a little crosstalk. Is there? Uh, oh, oh, where is that? Oh, that's coming from my phone. Never
I
mind.
was like, I don't think it's coming from here.
That's terrible. So I'm a volunteer with the Kidney Research Institute. A longtime supporter. I was there at the beginning, and you are a researcher at Kidney
hmm
Research, and you're
Yeah.
also at the VA. So it's kind of there's a Seattle research community, I guess. It's a couple different ways people get at it, and so there's the Northwest Kidney Centers, someone another
hmm
place I'm a volunteer with, and you're affiliated with. So uh, we're
Yeah.
we're we're on the same team. I feel like on a lot of things, but I wanted to talk about your recent paper in the American Journal of Kidney Disease. And so why don't you talk about that? It's really something I'm becoming increasingly aware of and thinking about is patient centered. What that means to have patient centered research, patient centered care, and there's so that's kind of a new place, and then it ties into patient reported outcomes. So I'm going to be on a
Yeah.
group with CMS on patient recorded outcomes. So I've been thinking a lot about sort of these topics, and so uh,
Yeah.
yeah.
Yeah, well, I'm first of all, I was really excited that you mentioned the paper to me and you had seen it because I actually sort of poured my heart into that paper.
Oh,
The history is that I've been practicing nephrology for sort of well, I don't know, 15 plus years, and taking care of patients even longer than that. Um, and I've also been doing research during that time. But this is and I've written quite a few papers, but this is the first paper where I really had a chance to write about something close to my heart and my own experience taking care of patients. The way that it came about was that I was invited to write curriculum on caring for older patients with kidney disease for the American Journal of Kidney Diseases. And um, I thought this would be a good opportunity to maybe, since I've been practicing for a while, sort of maybe share some words of wisdom, what I've learned during my career with fellows in training. When I submitted the piece to the journal, they actually didn't think it fitted very well with what they had in mind for a fellows curriculum. I think they
so what
wanted
what
sort
is
of
a fellows curriculum typically?
well, the journal has has a series where they're trying to sort of provide basic kind of building blocks for different topics for nephrologists in training or fellows. So I think they wanted me to write a piece on kidney disease in the elderly, um, and I injected a lot more sort of personal experience into that, and so they very kindly saw the value in what I'd written and suggested that it be prepared more as a kind of perspective piece, where I'm writing about my experiences. But yeah, the what I realized, they always say that writing is can be a little bit of a discovery process. And as I was writing this, it really helped me put into words a lot of what I had been experiencing and going through as a nephrologist. and really as a person during my career. And one of the things that hit me really hard as I was writing this is how hard we sometimes have to work in our healthcare system to center care on our patients, to make our patients, the focus of care, which is so ironic because I mean, isn't that what we should be doing? I mean, and I think no physician, no healthcare provider would say that the patient is not important, but I think the way a lot of our processes work, the way our training works, um, is we tend to focus on organ systems and diseases, which can be very
Lab
powerful. I mean,
results.
exactly, lab results, and you could think of this sort of broadly as kind of the biomedical model of health. It's very technologically focused and it's very powerful. And were it not for this model, we would not have had a lot of the treatments that we have available, including dialysis and many other treatments that are kind of miraculous. So I think it's very powerful, but I think what happens is that, especially as healthcare systems get more complicated and as knowledge becomes more extensive, and I think increasingly patients are becoming more complicated too. People often have not just one health problem, but many health problems, especially as they get older. I think what happens is that you have this sort of fragmentation of care where you as a provider, like for example, me as a nephrologist, I am taking care of this person's kidney disease and another person is taking care of perhaps their heart disease. And that's how we're trained. We are trained to be specialists in a particular organ system. And but what I've come to realize is that doesn't always work super well for the patients. And even if it might take care of a particular medical problem or medical issue, um, I think a lot of people come away feeling like they're being treated less than a person, in the sense that the provider is not looking at them as a whole person and seeing their kidney disease as just one part of the puzzle. And maybe it's an important part or a big part, but there's all that person's other health problems, and probably even bigger is their whole life outside the healthcare system.
Of course. Yeah.
We all know that health is just so much more than the medical system can provide. So anyway, that's sort of a long way of saying that this had been kind of stewing with me for some time, and I had a chance to write about it. And I got quite a bit of help from some colleagues who were kind enough to look at a draft, and I got quite a bit of help from editors and reviewers. So it sort of morphed into something a little different than what it was originally. But yeah, so that's sort of a summary, at least, of how I came to write about this.
One thing that is very true too, in my experience, is writing about this stuff does help clarify what your thinking is. And
Yes.
I've written a little bit about it just to try to also clarify my thinking. And I think you're right. From the point of view of the object of the care, it does feel sometimes like you can get lost. That
Mm-hmm.
you're just there so they can fill out the data on the EMR,
Mm-hmm.
the electronic medical records,
Mm-hmm.
and
Mm-hmm.
or that in being on dialysis, and how the payment works, and so you have to have a primary care physician, but a lot of times it feels like they're not managing the whole picture. They're more as just a
Mm-hmm.
referral, the way to get a referral to a cardiologist or the
Mm-hmm.
endocrinologist or whatever it is, and
Mm-hmm.
so it can be very frustrating to be the subject of all this, it, and so you went through five strategies, I guess, for
Yeah.
creating patient-centered care or providing patient care this is from the perspective of a physician, and I guess for someone on dialysis, of course, our interactions are so much more with other people in the just in general. We're much more involved with people in the unit, and so it's and so when you talk to us about our care, I think a lot of times we're thinking more about that. And so I think one thing is like, how do you get what you learn from listening and being, to the person in the dialysis unit, to the nurse, who's doing the blood pressure checks or whatever different medicine it is. And that's where I think there can be a breakdown, that it just feels like nobody's really listening, or it can be dehumanizing, I guess, is some of it.
And it's troubling to hear that. And I really think this is the kind of thing where there needs to be almost like a culture change, because, I think there are those physicians who practice this way. There are probably nurses probably more so nurses who practice this way individually. But, unfortunately, our healthcare, we have limited control, right? So as you mentioned, as a patient on dialysis, you are cared for by multiple different people, ranging from the techs, from the nurses, social worker, nephrologist, all different kinds of folks. And I think one of the things that has been very neglected in medical training, and I think we really could use, is more emphasis on teamwork and how different healthcare professionals taking care of the same patient should be trying to work together as a team and to communicate with one another to make sure that messages are consistent, that concerns are heard, etc. And I certainly don't feel like that's done well in my health system, or probably any health system. And I always find it kind of embarrassing sometimes when I'm on the inpatient service and we have a habit of rounding on patients, usually at a time that works for us,
early.
And or late or whatever, or, after all the other teams have come in, and you're in the position where to really be able to know how that person's doing, you pretty much have to wake them up. And if they're napping, let's say, and you're not quite sure what other providers have been telling them, so you ask them. And I'm so embarrassed by that, because I think it tells the patient that the team is not necessarily communicating. And I think it's inhumane sometimes, that for our convenience, we wake somebody who's probably exhausted from being woken up repeatedly overnight. And unfortunately, that is not within the power of individual providers. It's like a health system problem. And I think there needs to be some kind of culture change and recognition that we need to work better together as a team. Of course, not a lot of that's in that particular article, but that you did hit on something there that I think is really important.
But and that does happen in the dialysis unit. I mean, you're undergoing a medical procedure, but staff can feel like you're just available when they need to talk to you or to do something, or so it feels infantilizing, really, that you're you have no. Obviously, I dialyze at home, so I don't have that issue. But I know that's a dynamic that it's corrupting to someone doing well on dialysis. And I think it was the TED talk you shared with me. It was a University of Washington anthropologist? Is that right? I don't have my notes in front of me.
Oh, was it the Victoria Sweet who talked about the inefficiency of efficiency of inefficiency? She used to be she's in San Francisco.
Oh, okay.
She used to be a rehab doctor at Laguna Honda Hospital, which
That's
is
right.
a rehab hospital in San Francisco. What did you think of her talk?
Well, again, it to me a lot of this and Berwick, it just feels like it relies on people's benevolence, like that. In order for these systems to work, the individuals involved all have to be on their
Mm-hmm.
game, and that just isn't the reality. That
Yeah.
most of your interactions is with staff who are hurried and rushed and have unclear objectives that maybe aren't aligning. It just feels like you can. So I'm not really sure. How. I'm more interested in systems that can withstand human imperfections and
Mm-hmm. Yeah.
frailties, and so it comes back with me is like I don't feel like looking at patient centered is putting it in the right spot because
Mm-hmm.
to me a patient that represents a business relationship and so you have a variety of these business relationships that can but really what is more what we seem to be talking about is more of a beneficiary level. It should be more of the interest of Medicare to establish your goals for care and then communicate those to all the providers that
Mm-hmm.
are servicing you. So it's not sure. It seems like it puts a lot of the responsibility for these outcomes on doctors, who I think it puts them in a tough position because so much of the care, the way you actually experience care, and the way maybe a good outcome versus a not so good outcome, especially in a chronic disease, it just relies so much on the patient. And I'm trying to remember.
Mm-hmm.
You sent me a few things to read, and it talked about instilling the vitality, somebody's will to live, sort of, just that's missing, and that's the difference in people is that that will to live, that the
Mm-hmm.
drive that keeps them going, and that seems like that gets sapped among people who are on dialysis, and
Mm-hmm.
I really think that when you get trapped in this chronic disease management where it's very all-encompassing of your life, you can be thrown into it, very disorientating. For
Mm-hmm.
many people, it's overwhelming, and they don't get back from that, and they get a sort of a learned dependence. It's
Mm-hmm.
something we've seen for decades. I mean, the first time I heard about it was a paper written in the 70s, The Marginal Man, which I can have a copy of, but it's hard to find.
Yeah.
But it describes that same idea of somebody being in another world of not really in the hospital sick, like you're going to get better sick,
Mm-hmm.
and not well in part of the world, and you become a marginal man. Somebody who is just doesn't matter to anyone. It really
Mm-hmm.
feels like,
Right.
and so that
Right.
and so and addressing that isn't going to be found in so like how do you um you know I don't know how the only way you can really as a system is tell people they need to find that like
Mm-hmm.
that
Mm-hmm.
that you have to go out and find that. I think travel and experiences can help with a lot of people, but
Mm-hmm.
it's an individual thing, and that's
Yeah.
that emotional part of a patient is missing, and it's a lot to ask a doctor to dig into that.
Yeah, yeah,
I mean,
yeah. I hear it absolutely what you're saying, and I think obviously you are absolutely right. On the other hand, I think we can support that process by respecting and really rejoicing in people's humanity. Um, I know I have been relatively fortunate. I have not had a lot of health problems, but when I have had to go to the doctor, it doesn't have to be a complicated procedure like dialysis. You rapidly become this partial person, and the sort of kind of down pat questions you get, how are you, but no one really wants to know how you are. This kind of automaticity in
Yeah.
healthcare can't help, it can't help people retain, their vitality, as you put it, and who they are. So I agree. I don't think we can give that to people. That does have to come from within, but I don't think we should be stamping it out
I
either.
feel that
That's
way.
part, I guess that's how I feel is,
So
and I
I
feel like,
agree with that. But I think you have to people have to understand and value that to not accidentally stamp it out, And so
sure, yeah,
I think
yeah, yeah,
whatever that takes for each person, it's
exactly.
it's
I think you,
it's a tough thing.
yeah. Well, and I think you hit the nail on the head there, where you said it's different for each person, and I think that's what makes. I mean, having been in medicine for some years, to me, that's what makes medicine fascinating. Is whenever you walk in a room, whenever you see a new patient or a patient you've known, it's you don't know what you're going to learn.
Yeah.
It's exciting, and I think unfortunately, I think that's going away in medicine. I think there is similar pressure. There's a lot of pressure, as you said. You mentioned the electronic medical record, the pressure to document, bill, to focus on lab tests, and all of the things that are very important to the sort of biomedical model of health. And and taking away the sort of the personal interaction, the magic really of medicine, I think is making it a less satisfying job for physicians, and I think it's leaving patients feeling less than who they are. And so I do think, and I don't think it's just physicians. I mean, I think everybody who's in this business, it isn't just a business or an industry, or it shouldn't be. I come from the UK where we have a single payer system, so I might be a little idealistic, but it's a it's a calling, I think, and I think taking care of people's health is a very precious, important thing, and so I think some of that has been lost by our systems, and I think dialysis is kind of the extreme because it is so technologically focused. And I mean, I've never seen any other treatment regimen that's so uniform. It's become. You have the privilege of dialyzing at home, but who said 4 hours 3 times a week is going to work for everybody? But if you look, at the numbers, I mean, there's very little deviation from that. So that alone,
If we could get to 4 hours, that would be an achievement. Many people
right?
are dialyzing, less than that, 3 hours, and it's very frustrating to me because I can induce the symptoms people complain about by not dialyzing. I can absolutely feel the way everyone is just the feeling of being unwell, the feeling of having no stamina, not being able to walk very far. I mean, I can make that happen easily by just not dialyzing. And so when I hear people describe those symptoms who are using dialysis, I'm like, well, have you tried dialyzing more? But nobody really can, and few people want to. And so it's very frustrating to me to feel like the medicine is being underused. And it's just that nobody can do anything. It's like nobody has any agency. The patient doesn't have agency because that's how long our time slots are, and we have 3 days. And the doctor doesn't have agency because that's all they offer is you can't go to a burger place and demand salads, and and then but it turns out you can because now McDonald's has salads, but no, and so and then providers say, well, we can't do it because Medicare won't pay, and Medicare says, well, we won't do it because you haven't proven that it's very beneficial to every person, and it just it seems really frustrating, I think, particularly to people who are able to get more frequent dialysis and know from our own experience that we can just induce these symptoms by just not dialyzing. And so if that's the case for us, leads us to think it's probably true for most people. But
Mm-hmm. Mm-hmm.
once your yardstick for what feels well is gone, it's very hard to convince people that they can feel better,
Mm-hmm.
and
Mm-hmm.
it's a lot of work and it's hard and all the rest. But
How often do you dialyze?
I try to dialyze at least 2 days on, one before taking a day off.
Mm-hmm.
Not
Mm-hmm.
have ever
Mm-hmm.
2 days off, but ideally I would dialyze 3 days on, one day off, probably to really feel my
Mm-hmm.
best.
Mm-hmm.
But it's
Mm-hmm.
hard, it's
And
hard
you
to
can,
motivate.
yeah, and you can feel the difference if you don't
Absolutely.
do
Oh
that.
yeah. So if I stop dialyzing, absolutely, yeah. I say it. People like to talk about dialysis like it's one thing. Like you spend $36,000 a year and you get that thing, and it's really
Mm-hmm.
not. You know, every time you dialyze, you extend your life by the exact amount of time that's passed since you last dialyzed. I mean, that's how I think of it. As soon as I stop dialyzing, a clock starts,
Mm-hmm.
and I don't know how long
Mm-hmm.
it is, but it's probably like
Same. Yeah.
2 weeks maybe that
Mm-hmm.
until I expire from not dialyzing. So until I dialyze again, and then it resets that clock. So I know exactly what is benefited by dialysis. I get
Yeah.
that extra day
Yeah.
back or those two
Yeah.
days, and so. But as you get closer to that day, where there's no going back, that you start feeling really poorly. I mean, you can't walk very far. All the symptoms you hear. You just the feeling of being unwell, the pressure
Mm-hmm.
on the chest. The tingling in the
Mm-hmm.
lips, the lack of appetite, not wanting meat. All these,
Yeah.
variety of symptoms. I was just in London for a week, and so I kind of did 3 in-center runs, but then I had a gap on my way back, and I definitely felt it. I mean, I can make it up, and
Yeah.
I don't feel
Yeah.
like it's
Yeah.
critical. But I mean, I mean, I
You can tell.
can't
Yeah.
can't walk, you know,
Yeah.
but a block versus for an hour. That. I mean, it's a marked marked difference. So
Yeah.
it's very
Yeah.
frustrating, and I think that experience
Yeah.
motivates a lot of patients, but you get tired of it once, after 10, 15
Mm-hmm.
years of saying the same thing. So it's
Mm-hmm.
gratifying to see you and other researchers talking about the patient experience. The song
Mm-hmm.
study in Australia,
Mm-hmm.
I thought
Mm-hmm.
that was really useful in talking about what matters to people,
Mm-hmm.
rather,
Right.
because if you can't measure what's important, you make what you can measure important. And I think
Right.
we've done that. I
Exactly.
think we've done that a
Yeah.
lot. Oh, look, we can
Yeah.
measure urea. Let's make that really important. And then these patient reported outcomes, sort of the feeling of care, those sort of things. If that is the sense of those are those are harder to put a lot of stock in. But at the same time,
Right.
we have to know that if we could measure it, it would be important probably.
Mm-hmm.
So
Mm-hmm.
it's
Right.
but I one thing I've learned being involved with the Kidney Research Institute is how many smart people there are working on these things, and I think that's really that's the best, from my point of view, the best reason for the Kidney Research Institute
Yeah.
is to
Yeah.
kind of.
Well, and likewise, I think that we are very lucky to have engaged patients like yourself who bring a wealth of knowledge to the research enterprise. And I am really excited about the work that KRI is doing there. Also, just more generally in the US, I think there's a lot more interest in learning from you guys. I think, again,
Yeah,
sadly,
it brings up
medicine has
something
been.
I'm really interested in. We've gone pretty long. If you have some more time, it's
Oh
about.
yeah, yeah, yeah.
So, just when you apply the idea of patient-centered research, like, so I'm thinking,
Mm-hmm.
well, when I think of that, I mean, it's like I'm not going to say to you, you need to study this or you need to.
Right.
I mean, that's. And so, what is patient-centered research? I mean, what are we saying? I think it's kind of so far it's meant to me. It's trying to get people to explain things more conversationally, maybe at least
Mm-hmm.
uh, establishing some goals for what we're trying to do, things like that, maybe. But
Yeah.
as far
Yeah.
as when you get really to patient-centered research and you want people involved, and you've asked me, I've participated in things, written letters, and would be on advisory panels,
Yeah.
but I'm never really sure what I'm bringing to the table to somebody who has an
Really?
established research idea and is going forward. It just feels like I'm not sure how helpful I'm being to the like what does patient
Wow.
centered research mean to
Yeah. Well, it's funny because that surprises me actually, Bill, because I feel like you and other patients and caregivers and people who are seeing things from a different angle than I am have taught me a lot and see things that I don't see. But I think it's obviously going to be more relevant to research that's focused on patient care as opposed to
sure basic
finding,
research,
the next
yeah,
drug to treat Alzheimer's or whatever. But even those studies, for example, let's take a trial of a drug to treat dementia. Um, it's I don't think researchers or the people who sponsor the research, the drug companies, the universities, necessarily know what is going to be the most meaningful outcome. We tend to assume that it's things like survival or fewer hospitalizations. And for the most part, I mean, I think most people are not going to argue with those outcomes. But um, sometimes we really miss the mark. Like I keep thinking about the hormone, the estrogen story, where there were some trials of postmenopausal estrogen use that showed we used to be prescribed liberally for symptoms of menopause, and then there was some trials that showed that women who took estrogen had higher cardiovascular risk, and so instantly everybody came off estrogen, and no one took it for a decade. And then, my generation, now we're starting to develop these symptoms. you know, Actually,
I
it's a
take a little
quality of life
risk, yeah,
issue.
yeah.
Maybe a little. Point being that, yes, being at high cardiovascular risk is not a good thing. And it wasn't like a huge increase
No,
in
no,
risk.
yeah,
But the symptoms matter. The
yeah.
quality of life matters. And
Well, that
and
was
so
that
I
was
think.
the argument around EPO somewhat too. That
Mhm,
argument's kind of
mhm.
been lost, but the idea that if there is an increased risk by inducing a hemoglobin of 13, maybe people are willing to take that risk. But
Right, right,
yeah, so I mean I think it um, but those arguments were never really weighed seriously by
right,
Medicare when they were setting those rules. Hard to
right.
know if they were right or wrong about that. I know a lot of people, especially in this city, are feel like EPO's gotten a bad rap, uh,
hmm
but
hmm
it was probably misused too. So it's so
Mm.
complicated. It
It is.
is
It
very
is.
hard to tease these things apart.
Yeah. And randomized controlled trials especially have a huge impact on practice, especially if they're like published in the New England
Right,
Journal or
right.
but if they don't measure the outcomes that actually matter to the end user, or the people who are caring for them, then should they be influencing our practice that much? So that I think that's one way. Even just simple things such as what you measure, what you choose as the outcome for a trial, how do you define success? Those are all things that I think researchers are starting to realize they don't have all those answers themselves. And that maybe they should be actually uh, asking patients to be involved from the sort of formative stages of
Earlier,
research
earlier in the process.
earlier. Right, right. My father is actually works as a stakeholder in the UK. The UK, I don't know if you picked this up when you were there, but they have been much more serious about engaging patients and caregivers and a variety of stakeholders in research and guidelines for a long time.
Hmm.
My own father is involved. My mother had passed away about a year ago from dementia. And so my father, who was her caregiver, is a stakeholder, and he gives input into all kinds of clinical trials. And I think his input is genuinely helpful because I think the people designing those trials, and these are mostly trials about how to support caregivers, how to support patients, not about how to cure dementia
Right, right.
necessarily. But I think, yeah, I mean, I think the input is invaluable, if
Yeah.
that makes sense.
No, I think it's nice to know that you're better off with it than without it. I like how to be most have the most impact and be most helpful. What was that would that look like? And I think getting engaged earlier, is one way. I certainly feel like I
Mm-hmm.
have, and that's one reason I had been wanting to do this sort of side by side video cast podcast for a while, because I get to have so many of these conversations, that it it's I'm hoping that by bringing that out to more people, then more people will see the benefits of research and
Mm-hmm.
what's going on, and also how to engage and how
Right.
to be part of it. So um,
Right. Right.
yeah.
Right. That's terrific.
So thanks
Yeah.
so much for being my first victim. I hope to have
Yes.
you
Thank
back.
you.
I knew you first from your work with palliative care, which is another area
Yeah.
I'm really interested in. So maybe we'll talk about that sometime or
Yeah.
after
That
your
would be
next
great.
paper. So all right.
Sounds good. All
Thanks
right.
very much, Anne.
There, Bill.
I
Yeah.
can
Well,
hang up